Hello and welcome to the latest episode of Digital Health Unplugged, coming to you from NHS ConfedExpo 2026 here at Manchester Central. I'm your host, Jordan Sollof, news reporter at Digital Health. Nice to be joined in the podcast arena on the exhibition floor by two fabulous guests. Firstly, Dr. Peter Thomas, Director of Digital Development and Consultant Ophthalmologist at Moorfields Eye Hospital. How are you, Peter?
Very well, thanks.
Great to have you. And Kate Warriner, Chief Transformation and Digital Officer at Alder Children's NHS Foundation Trust. How are you, Kate?
Yeah, I'm good. Thanks, Jordan. Nice to see you. Nice to see you, Peter.
Nice to see you too.
Great to have you both. Today the focus is very much on the proposed single patient record. The government's NHS Modernisation Bill, or Health Bill, first set out last month, includes a requirement for all NHS providers to share patient data to create a single patient record. Government says it will help join up fragmented health information and improve access to patient records across care settings. So very much at the heart of its plans to modernise the NHS. First question, for those who may have only kind of seen the headlines, what do you both believe is the kind of government's true vision here, and what problem is this trying to solve? I'll come to you first, Peter.
Yeah, I think you may have said some of it in that little run-up. So I think we have a significant problem clinically where we have access to certain information about a patient, and often that's information that's held by our own hospital, and we may have some information from neighbouring hospitals, but there's cracks and there's silos and seams between different organisations. So I think the vision is really to try and move from a situation where it's a bit of a lottery what patient information you have access to, and try and make it a bit more consistent, a bit more standardized, and hopefully get to the point where, I won't have a situation I used to have when I was seeing patients up in our Moorfields clinic in Bedford. So when I'd see kids up there, I couldn't access the notes from my patients who I shared with Great Ormond Street, which is crazy because the hospitals themselves in London are a couple of miles apart. So I believe that's the vision in order to try and get a bit of consistency and standardization so we don't have those cracks that patients can fall between.
Kate, obviously, kind of the idea of a single patient record isn't new. We've had kind of shared care records, we've had local health and care record exemplars and various interoperability programs. What do you think kind of feels different about this latest push?
Yeah, I mean, I agree firstly with Peter around the vision, and I think the LACRA programs as they were way back when, I think made some huge strides in some of this, and I think it's important actually to recognise the brilliant work that has been done in part across those programs of work. And I think what this looks to do then is do it on a much bigger scale, whereas I think the LACRA programs were quite contained into local geographies, but where we know patients, they don't necessarily stay in the same geography. The aim of this is to do it at a much bigger scale across the country, which I think should be recognised, and I think is a good thing for patients and for our colleagues and staff as well.
Yeah, Peter, you kind of touched on it, but obviously as a practicing clinician, what could a single patient record, what difference could that make to kind of frontline care, really?
I think what we're trying to do at Moorfields at the moment is try to move to a situation where we can manage patients a lot more independently of where they are. So we've done an awful lot of work with video consultations. We run a virtual hospital service, which we call Spark, that manages patients' referrals, advice and guidance. Increasingly, we want that to be able to manage patients in collaboration with optometrists on the high street or GPs, wherever they are. I think we have an issue. So, for example, about 3% of all the referrals we receive are for patients who are already under the care of a hospital eye service for the same problem. And when you take that 3% figure against 2 million referrals into ophthalmology per year in the NHS, I think it's that kind of issue that I can see as being eminently solvable. So if we make it easier for clinicians, and in that I don't just include, the regular clinicians we talk about, but people like optometrists on the high street who do 20 million odd appointments per year, if we make it easier for those clinicians who haven't traditionally had access to the NHS systems that exist, I think there's an awful lot of wasted appointments that we can start to crack down on there. So yeah, that for me is one of the major points to it.
Yeah, and kind of Kate, from a more transformation perspective, where do you see the kind of biggest opportunities here? Is it patient experience, productivity, population health management, or something else, or maybe a combination of them all?
Yeah, I think ultimately it's all of the above. I think we've got a huge opportunity to get this right, and I think more generally in terms of digital and transformation, they are absolutely hand in glove together. So this should be part of helping us to transform our services. And I see this as a huge opportunity around new models of care. We've talked and in vogue at the moment around neighbourhoods, shift left, and new models of acute care as well. So I think the transformation of those services and the transformation of those into different settings, the SPR opportunities in terms of ensuring that we get that right for our clinicians and for our families is really critical. I think then as a byproduct of that, almost you get a greater patient experience. Don't have to tell their story multiple times, and the care for them is delivered in the right setting, in the right place, with the right information.
Yeah, and I think that's really interesting. It's the transformation of the model of care that I think that this kind of program's a real enabler of. So, I spend a lot of time thinking about online services at the moment, and we've traditionally had this division where we've had certain services which we deliver entirely face to face, and we look for opportunities to say how can we take a pathway online. But actually, when you begin to break it down, the proportion of patients who you could manage purely online isn't the sum total of everything, where online can be a big contributor. And I think the concept of a hybrid pathway is really interesting, where some of the interactions are delivered online, but some of them are delivered with community diagnostic centre visits as well, GP visits, other testing centre visits. So I think what you can potentially have with a single patient record is the ability to support pathways where it doesn't have to be so rigidly owned by a single organisation, where the patient can move between different organisations within the same pathway, but the whole thing remains joined up. That's really, really hard for us to do at the moment. When we set up our imaging hubs at Moorfields, for example, we kind of need to own the imaging hub, but there's a lot of diagnostic equipment that we don't own that we could potentially tap into. But at the moment, those organizations that have that diagnostic equipment don't have access to the patient notes. So I think as an enabler of these hybrid pathways, letting patients move between different organizations, online, face-to-face, within a single pathway, I think that's the kind of service transformation that I would be excited about.
Yeah, absolutely, yeah. And we ran a story earlier this month on Digital Health News around the kind of government's claim that single patient records could prevent up to 20,000 A&E visits a year and save the NHS more than £20 million annually. I want to ask, I guess, firstly, whether you think that is a kind of realistic prediction, and also what would success really look like for patients? How would they kind of notice a difference once the single patient record is kind of flowing in action?
Yeah, well, I guess they're very bold claims and bold ambitions, but I guess that's right. So we should have those bold claims and bold ambitions. And again, if we get this right, this should make a huge difference to the experience that patients have. Not telling their story umpteen times. I think with this, then you'd hope for fewer crises, and Pete's point about the diagnostics able to have that really joined up. I think as well, in terms of what success looks like with this, I think the business change element for clinicians is really critical. And I think some of the learning from previous programs of work, in order to make this a success and to achieve those bold claims, I think that business change and the integration with systems that already exist and making the workflow as seamless as possible for our colleagues and our clinicians is absolutely mission critical to make this a success.
Yeah, Peter, anything to add there on those kind of government targets and success for patients?
I mean, for me, those targets seem pretty modest, right? I mean, £20 billion of savings and that number of sort of appointments and inpatient stays, it doesn't feel like an ambitious target almost. I mean, I've not been a junior doctor for 20 years, but I spent a lot of time on the phone, finding out what's going on with other patients. And we spend a lot of time, sort of wasted clinical time, wasted administrative time, trying to find out information from other places that could be freed up if we had easier access to it. And if I come back to that statistic so if you look at ophthalmology, it's the biggest outpatient specialty in the NHS, about 2 million referrals per year. If 3% of those referrals are being sent in where a patient is already under the care of an ophthalmology department, and a significant proportion of those are leading to an unnecessary additional new appointment, which is quite honestly the frequent outcome of it, that it feels to me like those benefits pretty quickly add up from there. So yeah, I mean, for me, those don't seem like hugely ambitious targets to set, but might have to eat my words on that.
Peter's looking for the job card to oversee this. I think Peter argue with those big claims.
Yeah, we'll see. Obviously, one of the kind of many have voiced their concerns, including the British Medical Association, about the kind of legislation forcing providers to share patient data. Yeah, that's kind of a key, I suppose, thing that people are a little bit worried about, I suppose, with a single patient record. How should the NHS balance easier access to information with patients' expectations around consent and control? 'Cause that's a hard thing to kind of balance, I guess.
I mean, I think we've got a communication problem for a start. Is that when we talk about sharing patient data, I think first of all, what is patient data to a patient? That's not a particular clear term to use. And when we talk about sharing, I think it often conjures up the idea that it's being shared with some external organisation. Most patients, from my experience, assume that we already share data between NHS trusts. I think, all clinicians have had the experience that a patient's incredulous that I can't access their notes from another hospital. I think they assume that, and I think there was some statistic about 60% of patients think we already have a single patient record across the NHS. So I think we need to be really careful about how we describe the data sharing. I believe personally that most patients would find it non-contentious that two hospitals or two different NHS organisations involved in their care would be sharing information. Now, certainly there are some more sensitive services. So, if we think about sexual health services, for example, there will clearly be some exceptions where we need to be more cautious about the data sharing. But for routine outpatient, inpatient data, I think most patients assume that we share it internally within the NHS. So very clearly separating that type of data sharing from other conversations around sharing it for insights, sharing it for research and development, potentially sharing it with external partners. We need to be really careful about conflating those. So I think we know what we're talking about when we say sharing data, but we understand that also means within the NHS. But when we communicate externally, I think a lot of people accept that as something which they assume we're already doing.
Yeah, I mean, I would just add to that. I think the key issue really is how we progress, but legitimately and safely. I agree, Peter. I think patients, why wouldn't they think that we do this anyway in terms of an expectation? And I think the NHS balances this now. So, we've talked a little bit about the local programs that exist. So we have this in place now in local settings. This takes it further. You see patients in your clinic, why wouldn't they want their information shared with you so that you can care for them really well? I think trust is really critical in this. So trust in the NHS, trust in the professionals that are caring for patients, but then really making sure in our design that we've got auditability, we've got really clear safeguards and really clear consequences actually if things are misused. I think transparency of that then for patients is then, again, a really important step in terms of the design of the SPR, so patients can see who's accessing their records, what they're accessing within them, and really openly and transparently and really empowering them and putting that information in their hands.
Absolutely, yeah. As I mentioned earlier, the single patient record, it sits within the wider NHS Modernisation Bill and the broader reforms to how the health service is run. How important is kind of leadership and governance going to be to the success of this programme?
Very, I would say. I mean, the governance thing we already touched on. I mean, as soon as you're doing something at very high scale with large amounts of data, there's an extraordinary amount of risk that goes along with that. So, the governance has to be really good to make sure the data is being shared appropriately and you've got all the security in place. I think in terms of the leadership, it's going to take quite a long time to deliver this. This isn't a simple program that's going to be something that's delivered overnight. So there needs to be, a clarity and consistency across probably a period of years during which I imagine there will be, more political changes happening. And I think one of the key things that seems to me, as having been an outsider around previous attempts, has been the conversations tend to get bogged down in the risk. And it's maybe we've not always been really good about balancing that about what the potential opportunities and the potential benefits are, and really translating it into really clear language about how it leads to better services, how it can improve individual patient outcomes, improve their ability to engage with their own care and understand what's being said to them in clinic by being able to review it at home in their own time. So, I think the leadership of making a optimistic case and a case for the benefits and not always getting fully bogged down into sort of firefighting criticisms.
Yeah, I would agree. I think the bit that maybe I would like to see in this is then the family and patient leadership in this. So what is it that patients and families want from this? And so at Alder, we do everything with the voice of children and young people at the heart of absolutely everything we do in the organisation, whether that be digital, whether it be transformation, some of our service design. And I think getting the voice of families and patients in the middle of some of this in terms of how we do what we want to do and then how we implement should be a key factor from a leadership point of view that should make this a huge success.
So yeah, that kind of flows on to my next question, Kate, which obviously with all the how working closely with children and young people and their families, are there any other kind of unique considerations around the SPR in paediatric care?
Yeah, I mean, I think sometimes children and young people can often get lost in some initiatives. So we know the NHS app has been a real challenge for us with children and young people, for really good reasons. But, we know that doesn't work universally for young people at the moment. So again, I would say getting their voice in the design of this is absolutely critical. The work that we do with them, they tell us, we want this. Why aren't you doing this? This is crazy that you're not doing this kind of thing. And in terms of children, they're born with an iPhone almost in their hand. Other devices obviously are available, but they can use technology before they can read, write, and talk. And so we know that their expectation on us, in terms of digital and tech, is really high, and rightly so. We then have a moral responsibility to be able to respond to those needs. And I think in terms of some of the considerations, clearly from a safeguarding and a CYP specific piece, there's some things that we would want to make sure, again, goes back to the safety and security point of view. And I think my final thought on this, I think other partners such as education are a critical part of children growing up. So you'd almost want to see, other partners outside of what you would class as your normal health and social care partners and organisations that are a key part of a children's life, as they grow up and experience services with us, should be part of the design of this for the future, and the benefits of it for the future.
Yeah. And Peter, obviously, Moorfields being a specialist provider, there's a lot of kind of patients often moving between organisations. How could a single patient record change the way specialist services operate?
Yeah, I think it's interesting that I think we're really good at clinical expertise in this country, and if we look at the likes of Moorfields, we've got nearly 200 consultant ophthalmologists, many of whom are highly specialised in some very, very rare eye diseases, and it's a repository of expertise that's pretty much unparalleled in the entire world, and yet it is geographically constrained to its area in London and the southeast. Yes, we have patients travelling from further apart in the country, but we have this sort of inextricable linkage between where the clinical expertise is and where the patient is. And I think there's a big opportunity for our specialist hospitals in saying, how can we move away from a model where the patient always has to come to the expertise, to where those specialist hospitals can can act as repositories of clinical expertise that can be accessed from somewhere else. So, in our case, if there's a patient with a really unusual presentation with, very unusual diagnostic scans of their eye in a very distant part of the country, why shouldn't it be possible for that patient to have an interpretation from Moorfields of what the eye scan is, and then access some of that expertise remotely, which can be delivered in conjunction with services on the high street and local hospitals as well? So I think for specialist hospitals to be able to essentially dip in to patient pathways remotely, that's a big opportunity for patients and for specialist hospitals as well. And an enabler for that will be having a single patient record, so that the entire thing isn't happening from scratch. It's not the patient being referred into the hospital, all the data being recollected, but rather the background is there and stored, can be accessed by the specialist hospital remotely, who can then get involved in the care. And it doesn't always mean not repeating the conversation. So I think sometimes, repeating the conversation is a very frequent complaint. But there is sometimes value as well in repeating the conversation. So, the conversation I would have about double vision with a patient, and when I'm talking about the symptoms they get from double vision, is probably very different from the conversation that an A&E doctor would have. And conversely, my ability to have a conversation about abdominal pain with a patient is very limited compared to an A&E doctor. So I think it will just make it much easier for us to get involved in patients' care remotely without having to repeat everything.
Yeah. Obviously, we know kind of the NHS operating across hundreds of organisations, different systems, varying levels of digital maturity. So how difficult do you think an SPR is going to be kind of in practice? And what do you think are the biggest technical barriers that still need to be overcome?
Yeah, so I think that digital maturity has actually increased absolutely dramatically over the last 10 years. So since, the LACRA programs and other things, there's been huge investments in local organisations, in electronic patient records, in digitisation. So I think the playing field is very different now. I think the standards design is absolutely key to really ensure consistency across other organisations. So an apple is an apple, for example. I think from a technical point of view, what we really need is clear standards with suppliers. Often, we don't get those early enough. But then also with that, then a lot of work that might be needed to be done locally. I think, it would not be a great thing if you had to have 200 flavours of something in local organisations. I think setting some of the standards and supporting organisations locally to be able to meet those national standards and those national expectations with then suppliers that are going to need to integrate with this single patient record. So my plea would be to help local organisations with some of those standards and mandating them with suppliers as well.
Yeah. Yeah, no, I'd absolutely agree with all of that. And I think we are definitely in a very different place in terms of digital maturity and, the NHS app compared to sort of previous attempts. That said, it can still be quite difficult to get a single patient record within a single hospital as well. That we still have silos within hospitals. I think probably part of it's about, the saying of not letting perfect be the enemy of good. We don't necessarily need to have a completely perfect system in order to get significant benefits from it. So when I think about, outpatient clinics and ophthalmology, for example, a very significant proportion of the information we need is simply in the clinic letters. So I think if we can go into it, pragmatically, understanding that it will take an awful lot of work to get every last piece of data in there, and probably that will never be managed, that every single piece of data will be in there, but pragmatically saying what is most useful, what allows us to deliver better and safer clinical pathways, and then being iterative in the approach. That for me feels like something that would enable it to be more successful than setting out a very clear specification that if we don't meet every single one of 200 different data items on day one, we judge it a failure. I think, being iterative and going for gradual improvement would seem the pragmatic thing to do.
Mhm. Last few questions then. If we're kind of sat here recording another podcast in kind of 5 years from now, let's say, what needs to have happened in that time, do you think, for single patient record to be kind of definitively considered a success?
Brilliant question. So I think something different to what we've tried before, a different approach, building on the learnings, of course. I think there's a design in something absolutely brilliant for our clinicians, but designed with our clinicians and designed with our patients. I think it's designed with a really brilliant user experience in mind, because I think we often see, clunky processes, clunky digital solutions. So I think, the opportunity of getting something that, really works intuitively for colleagues. I think with AI in the middle of it as well, because we see some of the opportunities of AI, how can that really, we can get ahead of the game, I think, with the opportunities of AI. I think investing in the change and not underestimating then the change in local organisations that's needed, and investing in local communities to really deploy it brilliantly. I think we can't afford to wait. I think this needs pace. We can't afford to be sitting here in 5 years' time and still talking about deploying it. So I think we need pace of delivery around it as well.
Yeah. Peter?
I think probably two answers, one from the healthcare services perspective and one from the patient's perspective. So I think it would be a success if we don't just regard it as a technology deployment that has happened, but rather to what extent has it driven changes in pathways? To what extent has enabled new sorts of services that are more accessible and meet patients' needs better? And then I think from the patient's perspective, I think a key one, I believe the intention is to surface it through the NHS app. I think one of the problems we always have is the quality of communication after a clinical encounter with a patient. And there's been lots of studies dating back decades showing that patients probably recall about half of what's said to them during a clinical consultation. Some of that's due to communication. Some of it's due to the fact that it's a very stressful time and there's a lot of information to take in and there's only a certain amount of bandwidth that can be retained. So I think patients being more able to access their records and will lead to them being more engaged with their care. There's plenty of evidence to suggest that. So I think that'll be a metric of success as well.
Final question then. I'll come to kind of each of you for a last comment on should NHS staff and patients be optimistic about the single patient record and why? Last comment for you, first you, Kate.
Yes, they definitely should. If we get this right, and we have a huge responsibility to get this right, but this has so much potential to really transform the lives of patients and families, and the working environment for our clinicians, really supporting the new models of care that we're aspiring to deliver across the NHS. So yes, absolutely.
And Peter?
Yeah, I mean, what's the point in not being optimistic, I suppose, in this?
Yeah.
I mean, it's, if it's done right and if it works, it'll be absolutely fabulous. You have to be realistic as well. It is a very difficult and a very large project. So I think the optimism should be balanced with, achievable goals. And it comes back to that idea of, how can we iterate up to something that's really good, deliver benefits that are concrete without trying to go for 100% perfect in day one.
Absolutely, yeah. Well, as you said, there's lots to be optimistic about, but ultimately time will tell as it pans out, and whether it turns out to be a huge success or whether it simply becomes another program which never quite worked in the NHS. We will see. But we've flown to the end of the episode, so I want to say a big thank you to Peter and Kate for joining me. Thank you very much. Thanks everyone for listening and watching us here live in Manchester, and watching back as well on various podcast platforms. This has been Digital Health Unplugged, live from ConfedExpo. We'll be back with another episode very soon. Bye for now. Thanks again.